Okay. Okay, great. So today we've long awaited, much anticipated, extraordinaire Courtney and her colleagues and friends from US Aging and AAAs have finally figured out a date to talk formally more about the applications of interoperability and all the challenges we face, but within the aging population. So thank you for agreeing. I know it's been a busy, whatever, summer or wherever we're at, with lots of presentations. So I'm really looking forward to it. So essentially, just a couple of updates before we dive into it. One of the things we like to do is just make introductions, people who are new to the call here, just to say who you are, where you're from. And I know some of our guests here may fall in that category. And then we'll just do two quick updates and then we'll dive into the work. So I'll pick Dustin to start, since there's a few new people.
Sure. Thank you. I appreciate this opportunity. Thanks, Courtney, for the invite. It's nice to meet everybody. My name is Dustin Ziegler. I'm Vice President of Clinical Integration at Sequoia Aging and In-Home Solutions, which is the largest area agency on aging in the state of Indiana.
Cool.
And I might even just turn it over to, I got a colleague of mine here who's actually the real smart person in the room, Kelly Stinson, who's our Data and Research Director.
Yes, so I am who he said I am. Kelsey Stinson, Director of Data and Research. Excited to be here and to share a bit about our work here soon.
Where you guys live? Are you in Indiana?
Indianapolis.
Yep. Indianapolis.
How's the weather?
Sunny.
Better than it has been.
Yeah.
Yeah.
You didn't average.
Did you get the floods?
Not like Kentucky.
No. That's good. That's good. So any other colleagues on? I know Nicolette. Let's say hello to you.
Hello, everyone. Thank you. And thanks again to Courtney. My name is Nicolette Wallace. I'm with the Mid-America Regional Council, which is the area agency on aging in Kansas City, Missouri. I'm a business technology analyst, so I work really closely under our director for the software and platform tools we use to manage our client data and our workflows.
Thanks. How about Jennifer? How about not Jennifer? As she struggles to find her unmute. There we go.
Exactly.
Where's that unmute button?
Too many different platforms.
I hear you.
Thank you, everyone. My name is Jennifer Raymond. I'm the Chief Strategy Officer at AgeSpan, an area agency on aging in Northeastern Massachusetts, and happy to be part of this conversation by invitation from Courtney. Thank you so much, Courtney.
Yay. Great. I think James or Jim Stowe.
Oh, James, thank you so much. James Stowe, the Director of Aging and Adult Services at the Mid-America Regional Council. We are a voluntary council of governments in the Kansas City metropolitan region, and the department that I oversee is designated as an area agency on aging. I'm really delighted to be here. Thank you, Courtney and US Aging, and for all of you for your time.
Wonderful. Glad you guys got quite the quorum. That's great. That's wonderful. And I think the only other new person is Maria, who I had the good fortune of speaking with earlier in the week from AD Vault.
Hi, my name is Maria Moen. I am the Senior VP of Innovation and External Affairs for AD Vault. We are a digital advanced care planning organization. What drew me to Daniel is that I also, in my spare time, I am the project lead for an HL7 standards project that is working on liberating people's advanced healthcare decisions, whether it's advanced directives, personal advanced care plans, portable medical orders, DNRs, utilizing FHIR to make those readily accessible across the healthcare continuum. So stop it, Jim, you are.
No, you are.
Now children, now children.
No, seriously, if you have any questions about workflows or processes for advanced care plans, DNRs, medical powers of attorney, Maria knows them, and arguably for all 50 states. And she has held school for HL7 Passio meetings on numerous occasions to help try and sort through how we do this with fire.
Well, you're sweet. Well, you know, and you know, there's a consumer facing aspect to this, right? There are underserved, you know, marginalized populations that we have health equity issues with. And, you know, we have got to make the playing field level for them. We have to get that information into the hands of physicians so that they can be respected as much as, you know, Bill Gates would be respected when he receives medical care. And obviously we're working with eConsent and the consent resource. So I was super excited to join today. So thank you.
Welcome, welcome. We oogled at the business process flows on the advanced directive work that we had the great fortune of observing and really learning from in many ways, that through the point of care partners and the research we did on promising practices, and that was amazing work. So thank you for joining. Great, cool. Anyone else new that I haven't wants to say hello or just wants to say hello? Okay, so just two quick things. This is probably also more for our guests. So the ONC has the eConsent Discovery Workshop next week. It's a half a day from 12 to 4. I'll put the link in, or somebody else can put the link in.
I just put it up in the chat.
Thanks, Brian. Where we'll be talking along with a whole bunch of other people talking about eConsent. And it's a great opportunity to sort of dive into the material. And we're so happy that ONC has finally picked up the mantle on this. And hopefully it'll be able to sort of move forward over time. And it's got so many applications and so many different communities and cohorts that it's really super exciting. So we've been working on putting it together. What we'll be doing, there's like 5 different sessions that folks will be involved with, but there's about a half hour at 3 o'clock when we'll be talking about the consent utility itself and kind of talking about where we're planning on implementing the proof of concepts and things like that. So feel free to join, and if you have any questions, just put them in the chat. With that, Brian, I was going to ask you to just do a quick update and then hand it over to Courtney and team.
Certainly. And the only other item I had was just to mention that we continue to get high praise for the work that both teams did at the CMS Gravity Connect-a-thon track. And we have another one coming up in just a month. The HL7 annual meeting, working groups meetings and Fire Connect-a-thon is happening September 17th through the 23rd. The Connect-a-thon will be September 17 and 18 down in Baltimore, Maryland. Unfortunately, it's only in person, no virtual or hybrid options. But it looks to be another very interesting opportunity to test interoperability and really test out some of the standards that many of us have been working on for the last couple of years. So I popped the link for that in the chat as well. And now, shall I introduce Courtney?
Please do.
Well, Courtney is a unicorn, a self unicorn, quite unique. She is, of course, as you can read, the head of corporate relations and business development for US Aging. But she got involved in standards, I think through ICFIS. Was it ICFIS or
Gravity? Gravity first.
Gravity first. And we ran into each other, and I guess I lured you into ICFIS and then into HL7. And I keep running into Courtney everywhere I go. And I go to far too many of these standards meetings, and she keeps popping up. She is nominated co-chair for the HL7 Human and Social Services Working Group. She is co-chair of the Direct Trust Information Exchange for Human Services consensus body. And she is the champion and voice of the AAA at a national level. She is just positively amazing. So I'm going to turn this over to Courtney so that she can both blush and say, no, 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 not really, and talk about how wonderful her AAAs really are. Over to you, Courtney.
Thank you. You stole my thunder. This is all about the AAAs. And Brian, maybe, all of those lovely compliments prove you're a little crazy, but that's okay. We'll go with that. I'm thrilled to be here today, and I'm even more excited to have the three agencies with me who are here today, because I think by the end of this conversation, those of you who have heard me drone on over the months about the Aging Network, their unique work, some of the unique things that we do, but also the unique challenges that face our network, specifically as it relates to data and interoperability, will really be much more apparent. And my goal is that you understand where we are situated in the integrated health world, the level of expertise our aging network has with social care, the challenges, the inherent challenges that some of our network face as we look towards interoperability, and the importance of finding a path forward. So I'm going to try and get through my deck super quick, because where the rubber really meets the road is with these agencies. And I want you all to be able to hear some of what's happening in communities with some agencies who are doing just absolutely outstanding and innovative work. And for you all, you'll be able to really begin to see and understand some of the issues we need to examine and look forward to more and more solutions. Some are already out there, but more solutions to how we piece this all together. Because everybody's been introduced, I'm not going to reintroduce AgeSpan, Mark, and Sequoia right now. We'll get to them shortly. So US Aging, who are we? We're the national membership organization for the Area Agencies on Aging and the Title VI Native American Aging Programs. Next slide. We're a 501c3 organization. We are member governed. What does that mean? That means that sitting on our board of directors is exclusively Area Agencies on Aging and Title VI agencies, directors or CEOs. We do not have other members per se. There's some alumni members and things like that, but in terms of our membership, it is exclusively AAAs and Title VIs. US Aging provides a wide range of information, education, and services to both members and some services to consumers at the national level. We also provide a range of tools and technical assistance to help the Aging Network and to help other CBO organizations in their work, in their social care work. But we are here to serve our AAAs. The programs and services we do at the national level, we do an extraordinary amount of AAA and Title VI research on our network, the services they provide, and the outcomes of those. Aging and Disability Business Institute. The Aging and Disability Business Institute was created specifically to help the AAAs and Title VI advance their business acumen. This really came out of the Affordable Care Act and that work in the care transition space, which was about 10 years ago. AAAs were kind of tapped on the shoulder to step into that space. And that was our first real work on a more national level with integrated care. That then led to agencies being involved in the rollout of managed care and the work we have done since that time that we'll talk about a little bit more. So the Business Institute is very active and works with all of our agencies, helping them go from things like culture change in their organization to go from just providing services under Older Americans Act to figuring out how to hold a contract with a managed care entity or a hospital system, as well as all of the other things they might need, certification and training, understanding how to do pricing and build out packages and partner packages. So it's a wide range of information that and training that happens under the Business Institute. We also host Aging Innovation and Achievement Awards, recognizing the excellent work of our network. We have nationally the Community Care Corps program, which is a volunteer training program to help agencies and their volunteer efforts across the country in providing those volunteers help provide services in the homes and at the agencies. We also are the fiduciary and administrative agent for Dementia Friendly America that focuses on dementia programs, and there's a wide range of research tools and support that we offer our network and others around Dementia Friendly America. Disability Information and Access Line. So DIAL came about during the pandemic, and this was an opportunity for us to leverage our elder care locator, which I will talk about in a minute, which is a telephone line program where we could reach out to those with disabilities, specifically in looking at their vaccine uptake and encouraging them to engage with vaccines as well as answer questions. So it was a unique opportunity to do outbound calling as well as take inbound calling. And that really supports and highlights the work that's been going on for a long time with the Elder Care Locator. The Elder Care Locator is the only national information and resource line to provide support to consumers across the spectrum on issues affecting older Americans and their caregivers. So it is that one place you can call and say, wow, my mom has this going on. What do you suggest? Who do I call next? And our call center will do a warm handoff to the AAA at the local level. And we have certified information specialists that manage these callers. And we manage about 500,000 calls per year out of that call center. We also have Engaged. It's the National Resource Center for engaging older adults to keep older adults engaged, active, and connected. We have a Housing and Services Resource Center, which is fairly new in the last year. This is looking at affordable housing and all of the issues attached to helping older Americans and those with disabilities connect to housing and the appropriate services that are also oftentimes needed by these folks. And then finally, we have the National Aging and Disability Transportation Center. Transportation is, of course, a huge issue for anybody in the aging and disability field, and we work in partnership with Easter Seals on that, which does, again, a wide range of providing information, education, tools, technical assistance, and other support to the aging network. Beyond this, we have some other initiatives, but these are kind of our hallmark national initiatives that we bring to agencies and to consumers. We also do a lot of training and technical assistance to our agencies, and certainly a tremendous amount of advocacy, both in the form of what you all see with people like me being in meetings like this, as well as on the Hill. Next slide. You all have heard me say this a million times. Our network was created by a congressional mandate. This happened back in 1965 with the Older Americans Act. Next slide. The Older Americans Act came into being alongside Medicare and Medicaid. The creation of the National Aging Network, the Area Agencies on Aging, happened in 1973, again, part of that national mandate. It remains a foundational core of the work that is done today. Every single AAA provides services under Older Americans Act. The act applies to those age 60 and older, and it targets services to the most frail and vulnerable populations, as well as special populations, veterans, minority, low income, limited English. I would say, Maria, if you're looking at marginalized populations and health equity issues, you're sitting with the right group today, because our folks focus on those. Next slide. So you all, for those of you who have heard me in some of these groups talk, I have talked about the complicated space that AAAs exist and work in. Part of that is because while they receive federal funding from Older Americans Act, that funding and the coordination of the aging network has other stakeholders. The funding and coordination goes from HHS and the Administration for Community Living at the federal level, down to the states, down to the AAAs, and the AAAs then contract over 20,000 local aging service providers. So there are a couple of really important buckets and stakeholders that do have imprint on what happens in terms of the service delivery, as well as some of the important issues to you all, like data alignment, data standards, and data exchange. Next slide. All of the AAAs play a key role in planning, developing, coordinating, and delivering a wide range of long-term services and supports. And they have local planning service areas that each of them represents. Now, to really understand the scope of the network, there's 622 AAAs serving virtually every community in the nation. There are a few states where they're very small or sparsely populated, and the AAA essentially sits at that state level. The 622 AAAs and the Title VI Native American Aging programs contract over 20,000 local aging service providers. So I know one of the other things I've tried to draw a distinction with as I talk to in these various groups and when we have conversations is I think there is a natural tendency to think social care means CBOs providing services in church basements. The National Aging Network is a nationwide, very sophisticated network providing a very sophisticated level of service that you're going to hear more about. The Older Americans Act is foundational for all AAAs. But because of that flow from federal to state to AAAs, there are, state imprints on control and decision making, as well as the law calls for some local control. So that impacts how you engage with them. Next slide. The AAA structure, some are independent nonprofits, almost 40%. Some are part of a county government, council of governments. We have 2, I believe, that sit in institutions of higher learning. Don't ask me why. So it is a mix, and that does impact sometimes what agencies can or can't do in their backyard or how they will organize that work. Next slide. The average AAA, their workforce is about 150 volunteers, 44 full-time staff, 17 part-time staff. That's average. You'll see in a minute, there's a big variance between some of these agencies. Next slide. Funding. You can see the average agency is sitting at 10 million, but look underneath that. That ranges from $200,000 a year annual budget up to a $284 million annual budget for an agency. So it depends who the agency is, what other work they've gotten involved in, what their funding formula is in their state, what their population size is, in terms of what their annual budget's going to look like. You can see on the pie chart, Older Americans Act makes up, about 40% of their total budget. You've got Medicaid waiver in there, and then you've got what I call the mixed bag at 32%, which is a wide range of different funding that an agency may have. Next slide. So all AAAs cover 5 core service areas: elder rights, caregiver supports and services, nutrition, health and wellness, and then that's supportive services. And the supportive services are those home and community-based services much what I think you all would refer to as social determinants of health oftentimes. That ranges from information referral, the in-home, the transportation. And, you know, I think everything, nutrition is probably the outlier that most of you would consider social determinants of health type of support. They also do other things. For those of you that may be a Medicare beneficiary, you may have been counseled by a AAA through that open enrollment process. 85% of our agencies hold a formal contract with or act as the state health insurance program in their community. They also, large number, do case management and the senior Medicare patrol. So they have a very broad and robust portfolio. Next slide. So outreach, a core role of the AAAs is to create local information, referral, and assistance. I'm sure some of you have heard a little stress in my voice as folks have talked about information and referral and bringing in other entities to do that work. And our AAAs can speak to this a little bit more. They've been doing this work for years. Next slide. AAA serve a broad range of consumers. You know, they serve those age 60 and older. They serve caregivers. They also serve younger consumers, those that have aging and disability programs, can serve those from 18 to, you know, older Americans. And we have some that go, as they say, from cradle to grave. We provide services to consumers that have chronic illnesses. We support caregivers as well as veterans of all ages. Next slide. So the non-Older Americans Act sources of federal funds, Medicaid waiver, the state health insurance assistance program, block grants, low-income home energy assistance programs, demonstration and other money from the Administration for Community Living. Think about things like falls prevention, chronic disease management, self-management programs. There's veteran-directed programs, senior core programs, and certainly demonstrations under CMS. So there is a real mixture of federal funds that can flow through an agency. Next slide. So when you think technology and data, you need to understand that under Older Americans Act, the states have the power to purchase platforms for the AAAs or to direct which platforms a AAA will purchase, or they can build state-specific platforms, or they can say, you know what, AAAs, here's money, go figure out what platform you want to use. So the state has a real role in making decisions about what those technology platforms can look like. And many states are very directive oriented about that. Other states do provide the agency's voice and vote. The other thing that the AAAs do is they complete OAPS reporting for Older Americans Act. This is a requirement for them. It's Older Americans Act state performance reports. These reports historically have been a kind of service units provided type of report. And again, I'll let the agencies speak more to that. OAPS has a new reporting system that's being rolled out in 2023. And they have been working to align the data as well as to make those reports more useful. Now, if you asked me 3 years ago about the largest 10 AAAs in the country and the smallest 10 AAAs in the country, how many data sets they had related to nutrition, the answer was 11,000. And that's because each state was able to decide their data sets. Now, there has been some alignment going on. However, the data that exists under OAPS does not necessarily align with the efforts that have happened under the Gravity efforts. So you need to understand there's some natural disconnects here, and the state has a real voice and vote on a lot of this. They get to decide the salt content in their backyard. they can decide how a ride is defined in their backyard. Again, some of that may be aligning more, but we're not to total alignment and standardization. Next slide. So the AAAs provide a variety of services also through these healthcare contracts. 50% of our agencies are now contracting to provide assessments or screening for health-related social needs. Oftentimes it's food security, access to safe and affordable housing or transportation. The services run the gamut from care transitions to home care services, assessment for long-term services and supports eligibility, care coordination, and case management. Nutrition is a popular one, evidence-based programs, and then transportation as well as others. So we're seeing managed care organizations, health systems, PACE organizations, and again, these agencies can tell you more about their individual contracts. And know that this work creates added requirements and stress to an agency's data sets, to their data exchange, and to interoperability issues. And you will hear, I'll probably, Jen, have you talk about the number of portals that you have to input information into. So we want you to understand some of the challenges that exist in this integrated care world for CBOs and specifically for our aging network. Next slide. So some of the issues of concern relevant to our network related to data and information exchange, data alignment and data exchange requirements. Assessments. I think many of you all have heard me say what we consider assessments to be and what many others consider assessments to be are two very different things. Our assessments are very hands-on in the home, extremely thorough and robust. INR intermediaries, given the amount of work that our folks do, and someone recently said to me, wow, AAAs are their own hubs. They don't need a hub over them. I said, exactly. So INR intermediaries become difficult for a lot of reasons. Good referrals. We're obsessed with good referrals because we've seen good referrals and we've seen bad referrals. And I call it the garbage in, garbage out syndrome. If you get a good referral and you take someone through the process, you're also going to have good data. If you get a bad referral, not only are they not going to get the services and support they really need, you're also going to wind up with bad data, which should concern you all. Data ownership is of concern to us, and we know concern to the rest of the world. Consent, Jim, I always think of you when I talk about consent. We're worried about consent. We also think that the network is uniquely situated. We are trusted partners in the community for populations that oftentimes have trust issues with healthcare and are worried about consent. And so we sit in a better place, we believe, on consent and the ability to help that process than some others in the system. Endpoints worry us because when I hear folks say that a social health referral platform is an endpoint, the endpoint is the service and the consumer. And then open and federated directories is something that we're watching and have concern with, and will continue to engage in those conversations. And next slide. Is that the end of my slide? Okay, so before I jump in and ask SACOA to go forward, you can go ahead and shut out the slide. I think, why are we here? Why do I show up in these standards groups? Why does this matter? Why should you all care that we're around? 86% of adults age 65 and older want to stay in their homes as long as possible. They need help doing so. Not only do they get better outcomes by staying in their home and having these services and supports, it is much more cost effective for the system. 5.8 million older Americans have dementia. 80% of them live in community. 30% of those people live at home alone. 43% of older adults are lonely. 27% report being isolated. We know now thanks to a lot of good research, that being isolated is the equivalent of smoking 15 cigarettes a day on your health. 86% of older adults have at least one chronic disease, according to the CDC. 61% of older adults have at least 2 chronic diseases. And so we're looking at an older population that has extreme healthcare needs. And we're looking at people, it scares me to death that 30% of people with dementia are living alone. Their safety net is the social care system. And in this country, Congress created a social care system with the AAAs in every community to step in and help them. So I think that's why we need to care about how we're aligning healthcare and social care, because the stakes are very high. And what does that look like? So I've just dumped a lot on you all, but I want to turn very quickly, because we have a lot more to do, to Dustin and Kelsey. And these are our folks from Indiana. Real quickly, between these two agencies, as well as Jen Redmond, who's going to be a peanut gallery during Q&A with us, these are excellent agencies doing amazing work. We have an agency that's contracting with their health information exchange. We have an agency that's involved in trying to align data with the Gravity Project data. So these are sophisticated agencies that can really bring some thinking in terms of alignment and how do you drive successes. Dustin?
Cool. Thank you, Courtney. Is our slide deck available, or should I share my screen?
Share your screen, please.
Okay. Okay, so thanks everybody again. This is a really important opportunity for us to share information, and very glad to be on this platform with everybody. So again, my name is Dustin Ziegler. I'm Vice President of Clinical Integration at SACOA, the largest area agency on aging in the state of Indiana. I could talk for 8 hours and still not get to everything. So for the focus of this, I'm going to take through the lens of what I live with every day in my role as clinical integration, and how we engage and interact with health and hospital systems. But through that lens, I think it's going to touch on everything that we're here for today. And then I'm also going to bring in my colleague Kelsey as it relates to the data components that are really, I think, imperative to this group as well. So basically everything Courtney just said about the AAA network, that's us as well. But through the lens, again, of clinical integration, this is actually not SACOA's mission statement. This is the mission statement out of the very complex mind of myself as it relates to when I engage health and hospital systems. In my humble opinion, and this is just me, I've been at SACOA for 6 years. I've been involved in the aging industry for a long time. I think the future, particularly specific to AAAs, 90% of our future is going to, in one way, shape, or form, be in association with the healthcare, clinical health system, hospital industry. And so with that being said, with that being such a strong part of our future, this is kind of the description that I provide to health and hospital systems when engaging them. And as it implies, basically, as Courtney mentioned, there is a lot that AAAs do. At the end of the day, what I try to describe to folks is that when you engage and partner with the SACOAs of the world, we're here to help health systems optimize the patient health outcomes of the most complex, large, expensive, and vulnerable populations that we serve in today's healthcare systems. That continues to only increase more and more. And so with that, that's the angle I'm going to take. And so again, SACOA is Indiana's largest AAA nonprofit by nature. We are the designated area agency on aging. We've been around since '74. We serve Marion County, which includes Indianapolis, Indiana, and then the 7 surrounding counties. Courtney touched on kind of the core fundamental programs and services that AAAs provide, and that's true for SACOA as well. When you look at this though, and you look at all these different service offerings, again, this is where I, in the lens of the clinical mind, look to translate that when you look at this list, it's not just outputs and the things that we do. These collective services that the social care experts of the SACOAs of the world create these care plans involving all these things. And this is the difference between institutionalized placement or not for our vulnerable populations. And so to give you an example, and this is just very specific to SACOA again, on average, somebody who is eligible, has a level of care eligible for nursing home placement, on average remains at home and in their community for about 3.5 years when they're on SACOA services. And so when you think about that, like for me, if this very moment I was eligible to go into a nursing home through SACOA's interventions and other AAA's interventions, through these resources, I'm able to remain in my home, in my community, in optimal health and in optimal independence for about 3.5 years. And generally speaking, that's 3.5 years of better care at a lower price with better health outcomes. One thing I really like to drive home though, too, when you look at this, again, this is just kind of a snapshot of the core services. This is what we do, but another really important factor is AAAs really are kind of that easy button, one-stop shop for everything. And that's what I try to explain to health systems too. When you have a vulnerable, complex older adult whose health outcomes are influenced so much more by just what happens in the clinical setting, and also, but just even more so what goes on outside the clinical setting. When we wrap all those services around through these resources, when a health system connects their patient to SACOA, they know that whether we provide the services directly or not, these folks are going to get connected to the services, resources, and support that they need to remain at home and independent, and with maximized health outcomes. So it really is, it almost sounds like a Cinderella, too good to be true thing, but it is a one-stop shop for these types of things for our health systems. With SACOA, case management is our largest service line. And what we thrive on is being very person and individualized, patient-centered when it comes to these care plans. So no matter where the setting comes from, when somebody is connected to SACOA, we meet them where they're at, identify their situation, what their needs are, and then based on that, what options are available to connect them to resources, services, and support, whether SACOA provides those directly, or whether we connect those folks to resources in their community to meet their needs. It's all based on that human-to-human contact, which is just crucially important for us, because that one-on-one just can't be replicated in any other domain. And so when it comes to those that we serve, this is kind of our ethos, really, when it comes to patient care and coordination.
Hey, Dustin, Mary Sarah had a question in terms of,
Sure.
Just to bust it open for a second. I think she was asking about the connection. Does it need to come from the hospital, or is it a bi-directional flow?
Yeah,
right?
meaning, does the person have to be admitted to the hospital and be in the point of being discharged, or could it just be somebody who can't live independently in their home anymore and the family's trying to make a decision?
Yeah, so really good question, and a good opportunity for clarification too. When somebody reaches out to not just SACOA, but any AAA, it can be on the behalf of anybody. So it can be the individual themselves. It could be Harry, who learned of SACOA from George at church. And, George says, you need to reach out to SACOA because they can really guide you into the right direction. A referral can come from anybody, including self-referral. And when it relates to my specific angle with our partnerships with health and hospital systems, the same is true, but no, they don't have to have any specific circumstance, nor does it have to be a physician order or referral. With our relationship, it's basically contracting with health and hospital systems because they're educated and know exactly what SACOA does and offers. And through that collaboration, it's kind of a more direct connection between the clinical setting to SACOA for the resources that they need. That's what that contract, the value of that contract. But generally speaking, yeah, anybody can contact a AAA. It could just be simply for information and referral. It can be as simple as, I'm just curious. I don't know what elder law attorneys are out there. I'm going to call my AAA and get that information. All the way to basically, I'm in crisis mode and I can't take care of my loved one anymore. And I need information about what resources are available, whether that be to provide in my home or institutionalized or anything in between. So yeah, it can be any referral from any resource.
Hey, Dustin,
setting.
I'm going to jump in and let's keep moving because we've got a lot to get through.
And so this is just a quick snapshot of our, just how busy we are. 12,000 care managed clients. You see down the bottom left, 84,000 calls answered. That's through our Aging and Disability Resource Center. And that's kind of that one-stop approach. No matter what somebody's looking for or refer to SACOA, they know that they're going to get connected to the right people at the right time. Now, when it comes specifically, again, this is the angle of my brain and my day-to-day, SACOA from a healthcare partnership perspective and the way that healthcare is going. Just like a lot of other AAA, SACOA is the expert in social care. And my role specifically, there's two different worlds. There's the community-based and AAA world, and then there's the clinical medical world. And these two entities kind of operate independently of each other. My job is to bring these two worlds together because they speak different languages, have different cultures, but don't always know that when those two integrate, that's the solution for the most maximized health outcomes for our mutual patient populations that we serve. And that's one of the angles that I try to instill in our healthcare partners is that when you partner with an area agency on aging like ours, it actually does trickle down to actual health outcomes that are beneficial to everybody. And on the right there, you'll see just some of the examples of some of the benefits to that, just naturally because of the interventions that AAAs provide. And so the purpose for all this, we've been around, SACOA's been around for 50 years, AAA Network's been around for 50 years. At the end of the day, when you think about a AAA, just like I mentioned here, we don't diagnose, prescribe, we don't do patient procedures, but at the end of the day, we are about 80% of health outcomes when you look at the evidence of social determinants of health. So, when you have the clinical setting in the four walls, that's one thing, but when the patient leaves that clinical setting, what happens to them and all the factors that influence their care, that's where the AAAs come in. And we address all those things in collaboration and partnership with the health and hospital systems and clinical applications through social determinants of health. And so with that, I'm going to bring in my colleague, Kelsey. We've evolved very rapidly over the last few years when it comes to data collection, measurement, and analysis, which is crucially important in today's world now more than ever. So when we talk about all this, obviously data and numbers drive what we do. And so with this, Kelsey, do you want to step in and do a little bit of an overview of your work with our data connections, our partnerships, and what that means for our organization?
Yeah, absolutely. And I did realize that I sent Courtney a slightly updated slide, but this is close enough to the visual that I'm building out, but I can be happy to share the full slide deck after. But to transition us to our data, one thing that I know is not unique to SACOA is a disconnection of that. Dustin and Courtney both have highlighted various services that AAAs and that SACOA offer. The different services are going to be tied to different payers, and the payers are going to determine the services that the systems that we operated in and what those reporting requirements are. So to build on SACOA's story and service delivery, I've grouped our service offerings somewhat by payer source. So we have our traditional AAA services, through OAA, and in Indiana, we have Medicaid waiver plans, and we're providing case management, options counseling, information referral, meals, nutrition education, transportation, so on. And Indiana's Division of Aging has identified a specific platform for us, which is CAMS, or Care Management for Social Services. It's a Microsoft CRM platform, and that's required for our Medicaid waiver case management services, which is by and large our largest service population, making CAMS our most utilized platform, holding most of our data, both in terms of proportion of our clients, but also in depth of the data elements related to the folks that we're serving. Demographics, care plans, assessments, billing, and then certainly the largest number of our SECOA employees are operating in CAMS. CAMS is also required for our OAPS reporting. I had never heard that acronym like spoken, so that was, thank you, Courtney, OAPS reporting. However, most of our OAA services cannot be entered directly into CAMS. So we have to report out of it, but we cannot record the activity in that system. So we're having to enter into other platforms. So in this visual, I've also identified VisionLink. That's our information and referral database that's used for client intake, resources, information assistance calls. We have two separate versions of a platform called QRide, one that's used for our transportation services, one for our congregate and voucher meals. And then we have Senior Express, which is used for our home delivered meals and the routing and delivery, in addition to some other smaller like Access databases that are created for smaller programs that I don't even have on this visual. So across these systems, there's much duplicative data entry, both for clients that may be receiving various services offered by SECOA, as well as for the OAPS reporting, which again must be completed in CAMS, but these systems generally are not communicating with each other, and generally are not compatible with formatting. So with OAPS specifically, we're having to pull manual reports or data sets from across the various systems and then transfer those into CAMS. And while those standards have been defined by OAA, and CAMS might have those fields defined, their source entry may or may not, more often does not match the standards at which they need to be reported in. The next bucket of care source is really what Dustin has spent much of the time talking about with our healthcare partnerships. SECOA currently has 3 contracts with health systems, where we're really creating continuity and creating a bridge to our traditional OAA and state waiver programs, where we're providing options counseling, care coordination, and care transitions. So for these services, the referral piece is starting from a centralized referral web form that we've created that will go directly to the embedded SECOA staff member that's working in that health system. And then they're going to be documenting, and this is what I added that I can build off of, they're documenting in the health systems EMRs. So that we're working in Cerner, Epic, and Greenway. And then that's where they're kind of entering their clinical notes for the health system, but then they're also going to be documenting in our CAMS system for the waiver services that they're continuing to receive with SECOA. And then lastly, we also have managed care partners. So SECOA has 2 contracts, one with Anthem and then MHS or Centene. In these contracts, we're providing care transitions, complex care management, home delivered meals. And with our managed care contracts, we had to identify our own database. And we found value in having our own database. So we're using FamCare for both of these contracts. With Anthem, we're only having to document in FamCare once and sending the reports to Anthem, and that's meeting their needs and requirements at this time. With MHS, we are having to document in both FamCare and the health plan system, which is TrueCare. And then Dustin, you can go to the next slide. So then moving on to our data exchanges, there are 2 that I wanted to highlight. And the first is we are receiving claims data for a specific subset of clients. And this includes duly eligible waiver clients, so that they have Medicaid and Medicare, clients that are enrolled in Medicare special needs plans that are managed by certain health plans that are like enrolled in this initiative. And this initiative and exchange was led by the Division of Aging. So the client mapping and identification is managed by the Division of Aging with the health plan to determine the overlap in the patient population. And then we're receiving the health plan utilization into CAMS, the system we're operating in. But again, it's only for a subset of a population that translates to about a quarter of our clients that fall into these managed care plans. So there's certainly value in getting access to this information and the data interacting directly with our primary database. We just don't have any visibility in the back-end process and maintenance, and it's just a subset of our population. So then in contrast, we do have a contract with our state health information exchange. The Division of Aging has not authorized interoperability with CAMS, but with us owning our contract with FamCare, we were able to set up that flow. FamCare is FHIR enabled, and so this is where the health information exchange data is going to feed into. But FamCare, again, only holds a small percentage of our clients, being those with managed care contracts. So recognizing as an organization the value in having this data and this information for our entire population, and not having any control and getting it into the system we're using, our kind of creative response to this was manually importing our CAMS client registry, so our case managed clients into FamCare, which then kind of pulls down that the HIE alerts for. This is happening manually. We're updating our roster from CAMS to FamCare weekly. But this at least now gets us the daily feed of alerts for our entire population, so we can implement care transition interventions for our entire population. And then we're also able to, do population health analysis, understand utilization trends for our clients. This gives us insights that support our partnerships with current health systems, and it helps us support the development of new, approaching new partnerships. And then we've also been able to use this access to implement a high-risk stratification tool that incorporates this, hospitalization trends with some other elements that we're collecting in another system to assign risk scores to certain patients and implement certain protocol. And then go ahead and go on to the next slide. So then just bringing this all together quickly, looking to the various systems that we're interacting with and receiving data from, and with having limited control and entering in just one system, SOCOA has invested in efforts to centralize our data, at least on the back end and reporting end. If for nothing else, for just better organizational reporting of impacts, knowing our true unique client count. So we've been working with a partner to help us in doing that. So working to join and cleanse and standardize our data and getting it integrated into a Tableau data lake. So that way this can at least be our centralized data hub, allowing us to use our data more effectively and holistically. So this has been our creative attempt, at least, at a solution to have better access and visibility. And I also just wanted to share this piece with this group to highlight that in the cleansing process, our data are being formatted to meet FHIR standards as well. But with that, I'll go ahead and turn it back to Dustin.
Cool. Thank you, Kelsey. And really, what Kelsey just shared is only within the last 3 or 4 years. We've come light years ahead when it comes to data. So a lot of achievements here over the just last couple of years, thanks to Kelsey's work. So moving forward, bottom line kind of, and I'll have another slide on the bottom line, but when it comes to this whole environment, particularly the changing healthcare landscape from the angle of what we see it, one of the biggest factors, or actually the biggest factor that has been most consistent in my world is education and training. When I engage health systems and hospitals, I have yet to encounter anybody who knows the full spectrum of what a AAA is, or the extent of the impact that we have on patient health outcomes. SOCOA is very lucky to be in central Indiana. We are a very, very health-oriented health sciences industry. We have multiple hospital systems. We have the largest medical school in the country. We have Eli Lilly Pharma, all these things. With that being said, people still don't fully understand exactly who we are and what we do until we sit down and connect those dots with folks. And so part of that with this changing healthcare landscape is how do we align these social care standards that we deliver to integrate and become the common norm with health systems? Because it does take both of us, clinical and community based, to come together to maximize these things. And so our priorities continue to revolve around that and development of new and innovative service care delivery models. And innovation in the use of technology and data is a driving force for us, as Kelsey just mentioned. And one thing to note too, AAAs are not created equal for the most part. Courtney mentioned there's over 600 in the United States. They're not all SACOA, and they're not all our partners. We're about ready to speak in Missouri. There's varying levels. And so SACOA's focus seems to be on innovation, the use of technology. And just an example as maybe one way to standardize things as we look to the future is, it may seem like a selfish, play on this platform that we're working on, but I think it's an example of, so we're working on a thing called Twain Health, which we think could be an industry standard to where the AAAs of the world who may not be as sophisticated or advanced and up to date as the SACOAs of the world, to use technology and innovations like we developed at SACOA with this, what we call a platform called Twain Health, to be able to be a tool that we can deploy within the entire network that gives them a level playing field to engage and interact with health and hospital systems the same way that SACOA does. And Twain Health is, in this example, is just an electronic referral delivery system between health systems, hospitals, and the referring AAA that better coordinates care and stuff, but fits into that model of integrated care and a solution for the AAA network as a whole to be able to have a standardized approach to doing what the SACOAs of the world are doing today. So bottom line, SACOA, just like many of the other AAAs, is a comprehensive, all-encompassing expert social care provider for our most vulnerable populations, and that's only going to continue to enhance as time, literally every day goes on. We remain focused, as much as we are into innovation and technology, person-centered assessments, human-to-human assessments are the focal point. Algorithms and other components of what we do will never take the place of our standard operating procedure. But what's nice is that when we talk about these information referral services, it is really a one-stop shop to everything that a client may need to optimize their health, wellness, and independence in the home and community-based setting. And so we're going to continue to focus on that, with also a larger focus on the fact that our clinical integration aspects remain a solution for health systems and the mutual populations that we serve, as particularly as healthcare continues to evolve into a value-based care system. So really excited about the future of what we're doing. I hope this kind of paints a picture about our day-to-day and maybe what could be replicated across the country. And I will turn it back over to Courtney.
Terrific. Dustin and Kelsey, thank you so much. I think this begins to put some meat on the bones, and you're going to get to hear from another agency in a minute. First, Bill, I wanted to come back to you and let you know that US Aging is actually N4A, the National Association of Area Agencies on Aging. We had a name change. So N4A is now US Aging. Our relationship with Advancing States is that Advancing States represents the state units on aging. If you look back at that flow chart where I showed that the money goes from the federal government to the states, then to the AAAs, and then our 20,000 local aging service providers. When you go from the federal government to the states, that funding is going to the state units. So the state units and Advancing States is a very natural partner of ours. And these AAAs work very closely with their state units in terms of their implementation of the Older Americans Act, meeting the requirements of the act, as well as the requirements that their states are allowed to put on top of them related to that. And they work with their states on data technology platforms and other things. In relation to the National Council on Aging, we partner with them on a number of things, a lot of things related to chronic disease management programs. A lot of those evidence-based programs align with a group that works out of NCOA. And our agencies, almost, I think it's 96% of our agencies offer chronic disease management programs. So we have a very close relationship with NCOA. However, NCOA is not part of the Older Americans Act the way the state units or the AAAs are. So they are not a mandated provider under the act like a AAA is. Now,
Thank you.
having said that, James and Nicolette, if we can move to you guys so that you guys can talk a little bit about Missouri, and Mark, that would be great.
Absolutely. Thank you, Courtney. And I'm going to invite my colleague Nicolette to jump in at any point. We just have a couple of slides, so she might need to clarify or correct something I say. And I'd also like to invite questions if they come up. I know we're going to have question and answer, but if we're missing what you're interested in, please do speak up. I really wanted to focus on some of the data discussion here, interoperability, some of the things that I believe this group is most interested in, since we have a good foundation already about what the AAAs do. And just want to let you know that, again, our Area Agency on Aging is in a voluntary council of governments. It doesn't represent all of them. There's so much variability, as we've talked about today. So just take what I say with a grain of salt, that this might not translate across every Area Agency on Aging in the country. I thought it would be helpful to talk about some of the challenges and opportunities we face in our data environment, based on a couple of things that I've heard this group has talked about already, and really the reality that we are facing every day in attempting to align our work with this value-based healthcare transformation that's occurring, and be more effective with limited resources and a huge growing population of people with chronic disease, older adults, and those who really need social care to thrive in their community. So the challenges first, we'll end on the high note with opportunities, but taxonomy is very difficult. We have seen that classification of data, classification of patients, of clients, varies tremendously. It varies, in fact, within our own agencies. We did an analysis in Missouri. Some of our AAA partners in different areas of the state looked across their service lines and found that their own employees and their data systems were classifying different types of data, different services differently within their own agency. So this gives you a flavor for the type of variety that you might face across the United States. What is called a meal in one area could be completely different from what is called a meal in another area. And there's a history and a tradition that drives that difference. And it's because we have been mandated and we've been cultivated to have a grassroots approach to services that are responsive to who we serve in our planning and service area. Those can be micro areas almost. And so that's what really feeds some of this variety. But it leads to problems with taxonomy when we try to engage with each other and when we try to engage with healthcare or federal entities. So just keep that in mind. I'm going to get to poor quality referrals later because we have a story that will go with that. But this is a constant challenge and it's been increasing in the last couple of years. And I just want to note that I'm completely biased, so I'm going to lay this out for you all to consider. You can identify my bias. I do not like sharps. I don't think that they're advantaging us. And I don't think that people coming to Missouri in black suits on a huge private jetliner from New York City with a data platform are going to be our savior. So I've said it and we can move on. Then some of the opportunities that we have, we are doing some remarkable things in Missouri of all places on trying to become platform agnostic in what we do. We have muddled through platforms for so many years and doing a variety of work and responding to different funders that we are hoping to adopt some of these core data standards at the federal and national level that will help our systems communicate with one another, not entrench us in one software vendor's portfolio, and allow us to keep these independent functions that are really necessary for us to do this wide variety of work that's just been covered. So we are trying to make sure that we align with FHIR standards that are coming out of HL7. We are paying attention to the Gravity Project, and we want what we do and what our subcontractors do to fit in with that data universe. So Missouri is looking at some of the gaps that are currently present in some of those standards and created an aging services data set. that's a little bit more responsive to some of the units, some of the activities that we see in the community with social care, and are adding those as an extension or supplement to fire and some of the other standards that are already out there. So that's actually a published standard and interoperability protocol through some amazing partnerships that have sprung up across Missouri. We are actually not leading them at MARC, we're just taking part in them, and they can be reviewed and commented upon. I do want to talk about our increasing technical capacity because, in fact, Nicolette represents some of that move. We have just really found that we need to make investments in people and systems to become more modern. And 5 years ago, I couldn't have even forecasted that we would have a business technology specialist on our staff who really is looking at systems, interoperability, how do we get data to talk to each other, and how do we get our contracted community-based organizations to come on board with some of these innovations. It's an amazing progress that we've made in a short period of time. And we've done so with very, very limited investment from any source. It's just, we're working on very limited budgets here. But we are making those investments, and we are taking seriously this question of data and how we speak to one another and other entities, and how we take our data and tell people the story of effectiveness and need in community. And all of this is fairly new in the past couple of years. So just wanted to put that out there and say that's still very important to us. Okay, I have a couple of successes here that I also want to draw your attention to, because I think the area agencies on aging are remarkable, scrappy, in community organizations, and they're doing great work, and we will move the needle on health outcomes in the United States and save us from actuarial bankruptcy that we are headed to right now under the current fee-for-service and health or medical clinical focus of our spending. One thing that we have done is we have process and platform agility. And that is because we are smaller agencies, we are in tune with what is happening on the ground in communities. And we have been able at our organization to really establish workflows, platforms that are responsive to projects and help to orient ourselves and our partners to the job that needs to be done. And we've done it very quickly. So some of the lack of bureaucracy in smaller organizations and smaller networks like the area agencies on aging represent, you gain some of that agility. And then this point has been made about in-home presence, but that happens because we are in the home. And again, I'm going to tie a story a little bit later to in-home assessment and the difference that makes. But I can't emphasize enough that clinical providers in a healthcare setting are not qualified to do an assessment of social health needs with individuals. They just aren't. I'm sorry, I'm not qualified to conduct an X-ray. They aren't qualified to identify social need. They can do great screening, but when you need to escalate to a full assessment, that should happen where a qualified and credentialed professional, someone who has trust, someone who looks like who they are assessing, speaks like them, and can really relate to them in their neighborhood and in their in-home setting is vitally important. I did want to mention, because I've heard it's important to this group, our sensitivity to consent is well honed. We have conversation about where data will go, what data elements we will gather. We have conversation about what we will do with those data, who will have access, and our people say yes. In the context of those conversations, our clients say yes to consenting to share their data, and that's because there is a trusting relationship that's occurring. There's a conversation that's occurring, and if they say no, we respect it. And one other strength and success that we've seen is the model of networking, where us as the Mid-America Regional Council, the Area Agency on Aging, acting as a hub over community-based organizations in our region really does work. I mean, it actually is working to provide technical assistance, resources, back office, administrative capacity that's just not available at a smaller 501c3. So they can raise their hand and more easily say, we would like to take part in this healthcare initiative. We want to have an impact in our neighborhood accessing those funds. And that's because the network model has worked well. Okay, this is what we face with some of our healthcare and our federal data systems and some of the activities that we are doing. we've actually, I think this might be unique. Okay, again, take my words with a grain of salt. Not all AAAs have this environment, but in our healthcare contracts, our integrated care contracts, we have found that there is more freedom in platform selection and configuration with our healthcare providers than there has been in some of our federal reporting. And that's because I think so far, healthcare has not standardized their approach and connection to a social care provider like an area agency on aging. So they're allowing us to have some freedom and flexibility. We've built upon a Microsoft SharePoint platform of all things, an environment to communicate in a bi-directional fashion and a secure fashion with many of our healthcare contracts. It's not panacea. It doesn't do everything, but it's extremely cheap. It's easy to develop in-house, and we've been using that as kind of this facilitator of exchanges with many of our healthcare partners. We're running contracts with the Veteran Affairs Administration, Medicare Advantage, commercial insurance, and state adult protective services right now. And we expect some of that to grow. But even in that array of contracts, you can see it's kind of limited. And we don't have any health system contracts. Hospitals in Missouri don't operate under value-based care. They don't operate with risk about long-term health outcomes for their patients, and therefore they are not interested in paying for social care services in Missouri. So our market here is a little bit less mature than maybe on the coast. And we do have integration, and this is not, I'm not trying to oversell what we have. This is light integration, but we have 5 downstream CBOs really working in our systems, using the data. Their people are in it every day, and they are credentialed in our systems and accessing those via portals. And then many of our even further downstream CBOs will have some relationship to entering or receiving data from our data systems, but they're largely operating on their own systems and own platforms. Okay, and then just a little bit about the federal side. We are one of those states that our state unit on aging said, go ahead and purchase your own platform for your federal data. You don't have to, you're not beholden to what the state says. So that's a little bit of freedom in Missouri. It's called Aging IS. It's a pretty antiquated solution. They are modernizing. We have a modernization effort, but it's hard to get data pipelines in and out of this thing. I don't have a dashboard. I can't tell you what's happening with my neighbor area agency on aging, and the state unit on aging cannot see across the state of Missouri what's happening at all the area agencies on aging. So we have to piecemeal together reports, piecemeal together identifying gaps, and it's something that we're working on. And across the state, there's limited capacity for these area agencies on aging without collaboration, without a network approach to just stand up new platforms, enter new data, even have the staff to consider the first step in making some of those moves with new data platforms. Okay, so that's our software and platform environment. It's varied, it's wild, and I'm sure my colleagues can tell you stories about how it's the same for them. All right, then one of my favorite parts to talk about is what we experienced in the KC market with referrals under an experience we had with a large health insurer bringing in a Sharp. So we're interacting with this health insurer on the commercial side of their business line, and they had these comprehensive primary care clinics located throughout our region. They brought in a Sharp to make sure that all of those providers in those comprehensive primary care clinics could conduct social determinants of health screens and then make referrals out. Well, as you all know, if the services aren't actually funded, then a Sharp is a bridge to nowhere. You can make a referral out, but if there's not funding that accompanies that for the service to be delivered, ultimately, you're just referring into potentially wait lists. And that's what was happening in our community. And there were some other dynamics present as well. This really frustrated members after a referral was made. They were screened for a social determinant of health positive. The referral went out through the Sharp, and then the responding community-based organization had no funding. The person was ineligible, and the loop was not being closed, although when the platform was being marked as closed. And that really angered providers. They got super angry because now they told their members who they were treating, and they didn't feel very comfortable with social determinants anyway, that they couldn't close this loop, and it caused a lot of problems. We talked with one of our local contracted community centers, and they said, we got a really urgent referral with a family that needed food, and they weren't eligible for the food that we offered. And we were kind of left just running around trying to connect them to a community resource. It had nothing to do with how we were listed in the SHARP. We don't know how this happened. And I'll tell you one other thing, and then I'll get off my soapbox, but in the past, since SHARPs have come to market, my organization, the largest aging services organization in the Kansas City metropolitan region, has not completed one successful referral under a SHARP the entire time. Not one. So it's not operating here. So that's why I'm emphasizing that what we did to make a solution with that health insurer was find a way for their clinicians to connect directly with us as the network hub, the center of these community-based organizations, and do actual assessment after their social determinants of health screen. And then we, of course, in our relationship with community-based organizations, could send a member out for meals. We could have the transportation orchestrated. We could have the additional services that were funded in our agreement with that health insurer completed. Well, as that might not be surprising to you, the members then were served, they were happy, and that made the providers happy that something was actually occurring. And then we could talk to the provider about how that case progressed and what we were doing for them and how it was improving. So having kind of that centralized approach to coordination and navigation with paid services throughout, and it really, really satisfied the health insurer, and they're still contracted with us today. And that occurs because you cannot just send referrals out to community-based organizations and hope that they can respond, but it has to be thoughtful and funded. So that is kind of our disposition with data and interoperability, a little bit about our lived experience, trying to make a rather small agency be professional and really operate at a high level technologically in this healthcare ecosystem. And I will turn it over again to Courtney.
Thanks so much, James. All right, we've thrown a lot at you. We also have Jen Raymond, who is on the line, and I would love to have Jen jump in here in just a second. But before we do that, I'm really curious, the folks who are on Project Unify week to week, comments, thoughts? Does this surprise you? Is it way more complicated than you thought? I just love a little bit of feedback that then our folks can respond to, and certainly any questions.
Courtney, I'll make a quick comment. It was an excellent presentation. And I know a lot about the community-based organizations, how they work. What I think you touched on for me that people don't talk about a lot, but I look at what's happening now, and it's sort of the tail wagging the dog. You follow the money, and healthcare has the money. And I agree 100%. The referrals don't work. The social determinants of health, they do not work over there. And it should be the human services that is actually running the show, because the data shows if we provide those needed services, we reduce healthcare. Yep. And when the healthcare, when they find out about the individual and make that referral, it's too late. Human services should have been involved in the first place in doing that to prevent that. So I love the presentation, and it touches on something that's not talked about a lot because we tend to follow the money, and healthcare has the money.
Well, thank you, Bill. Any other observations?
Yeah, I'll say just a few things. Thanks again, Courtney. This is a fire hose of great information, and the my mind is spinning relative to the unfortunate overlapping issues that are faced in the other part of the population. There's a lot of questions, but it makes sense that because of the interaction and because of the commonality of the challenges for so many of the information related kinds of challenges that we each face, everybody faces, but particularly the aging folks face, that there ought to be more collaborative work. And as we do our work and I wanted to mention, next week we've got this consent utility meeting opportunity, and to invite your folks to join that. Brian put up the link on that. I think this deserves many additional conversations and sort of almost working group kinds of level of involvement, assuming that we actually implement the consent utility in New York and Minnesota and other places. It's the start of something, and at least that piece provides a link, a very clear linkage, very concrete way of connecting the dots. Because otherwise it's the oceans meeting and you'd get lost. But around the consent piece, it is really allows us to replicate and the scope and the scale of 622 different agencies is quite something. So I would propose that we'll follow up also with a note to say maybe we'll do another brainstorming session in the next couple of weeks or so, and have people have a chance to digest this. We're recording it, we can share it. There's a lot of technical kind of conversation, even from SharePoint. There are people who are working in SharePoint at scale. It's nothing to be embarrassed about, but there's, the reality is the reality, although our healthcare providers can't, oftentimes recognize that. So I would just, just put that up there before. And I just need to say, I need to jump in about 5 minutes, but we're going to leave that open. And for those who want to stick on for a while, it's fine. We can capture our ideas and have more of the conversation. Because I know people are hungry to kind of dive into some of the components of it.
I should add in here that we have had discussions this past year about the idea of starting up an aging working group,
right,
to complement our in effect our pediatric working groups through a lot of the work we've done with the CMMI Integrated Care for Kids program, and we've had a education working group. We're trying to stand up a child welfare working group. So there may be an opportunity if any of you folks are interested in joining us here in Unify to do more work. And the work that we demonstrated at the CMS Connectathon in Gravity is a direct consequence of the Integrated Care for Kids participants over the last few years, feeding their requirements for how do we do referrals? How do we do social care referrals from the healthcare side of the world into the social care side? And that was tremendously valuable. And suddenly having Courtney appear on the scene and help school us in what we really need to be doing for social care in general, as well as for the older Americans, it has further helped to evolve the work that the technologists and the vendors who are participating in this have done, as Courtney can attest to the subtle and yet rebellious user stories we attempted to tell at the CMS Connectathon of a healthcare practitioner submitting a referral for further assessment to a AAA.
Which, Brian, I applauded that like crazy, and we thank you for taking our user story. I'd love to real quick, Jen, can you jump in here? Jen is with another AAA age span. And again, I want to remind everybody, the agencies that are on here today are leaders. And these are agencies who are innovative, who have a diverse book of business or portfolio, so to speak. So, a reminder that we have agencies that don't have these capacities. But Jen, what else didn't we cover? What do you want these folks to know?
My gosh, I am so proud to be part of this agency after hearing what the Mark and Socoa folks had to share. We've been doing this work here in Massachusetts for almost 15 years in terms of healthcare integration and thinking about SDOH before it was called SDOH. And so, in addition to what everyone had says, I would say the time is right now. I have sort of never seen more momentum behind the idea of, gosh, maybe the utilization savings can happen on the housing side, on the nutrition side, on the navigation side, maybe fewer procedures and diagnoses codes, might be better. The great fear that I have, and I won't go as far as James went, although I'm right behind him, but the great fear that I have is that we're not the only ones. Those of us on the social side are not the only ones that are recognizing that the opportunity is now, and that there are others who don't have that same commitment to community, that don't have that same commitment to health equity, that sort of have a commitment to shareholders and others that are, you know, maybe a little bit smoother talking about the work than they do than the wide variety of community-based organizations. So the time is now, and we could use all the help that we could get in helping folks to understand the value of local embedded community-based organizations doing this work, as opposed to farming it out to some national entity that's not going to know where the food market is on Thursday as opposed to Tuesdays, that kind of thing.
Well, and the one other thing I'll say to follow up on that, Jen, and for the other agencies, is I feel like the Aging Network is uniquely situated to help solve this problem, to help figure out this interoperability, to help figure out how we properly coordinate with integrated care and partner in true partnership, because a lot of the downstream providers, a lot of those 20,000 local aging service providers that we contract don't have the capacity to work through these issues. And I think our network is a little interesting that even though we've been on the ground doing Older Americans Act for years and years and years, we have also spent the last 10 years investing in business acumen and learning how to be partners to the integrated care system. So I would say, I think we have a unique opportunity to let others stand on our shoulders as we move forward. Other thoughts, questions from anybody? Anything we can answer? I think we did it.
I have a question. Yeah.
Yeah.
Go ahead.
Go
Matt.
ahead, Matt.
I was wondering if each of the AAAs could have a, you know, if I could wave my magical wand and create a technology that would help my organization, what would that be?
All right, AAA, speak up.
It's a deep question. That, I mean, I can speak for SACOA. That's one of the things that we're looking at, that not just here within central Indiana, trying to develop solutions that can be impactful across the entire network. So I touched on this concept called Twain Health very, very briefly, but in an ideal situation, I feel like if SACOA has some of the challenges that are being identified with the solution that we developed, it probably means that a lot of other AAAs are too. And so hopefully with specifically to Twain Health, it would be ideal to have like a standardized across the network platform that could be a solution, not just for the SACOAs of the world, but even those kind of like, I mean, dare I say, and forgive me for saying, like mom and pop AAAs who may not have the sophistication and advancement of us in Indiana and Missouri, but could be delivered a tool that could go to market to health and hospital systems, to other potential business partnership arrangements to better amplify the success of AAAs across the entire network. So that's kind of a broad big level statement, but it seems like interoperability and a standardized solution from our perspective seems to be what's in everybody's best interest. It's just a matter of getting there.
I would just say, you asked the question, what's the technology? And I'll be really transparent and say, I don't know. I don't know what the magic bullet is. I only know that we need to have the right people at the table who are designing that and creating that. And that doesn't include just healthcare and technology and community-based organizations, but it probably includes the consumer and the participant as well. So, more than happy to be part of the conversation and willing to stay very open as to what this looks like in the end, as long as the right people are at the table making the decisions.
Anyone else?
I'm gonna like half respectfully disagree with Dustin, but I absolutely think interoperability standards and a standard in how we format and share and consume data would absolutely be helpful to communicate across AAAs with our partners. I'm less enthusiastic about the idea of a standard platform because all of our AAAs have slightly different portfolios, have very different markets, and have different sets of work they do. And so I think the idea that a single platform could plug and play in all of those contexts is perhaps a bit aspirational. But I think if we treated data with a standardized lens and then treated platforms as choose the platform that meets your individual needs, that can consume that data and use that data in a standardized way, that would be the kind of solution that I think would be most excited about, or the kind of technology we're most interested in looking towards.
And let me jump in here, and I want to see the AAA heads nod. I assume you'd like to input data once, not 6 times. I assume that you'd like one platform, not 5, 10, 15. Yep. You'd like to be interoperable. You'd like to communicate with anyone that needs to make a referral to you and anyone that you need to respond to. So I think what's interesting is some of their needs are very straightforward in terms of their day-to-day operations, and what kills them from a resources, a timing perspective, as well as loss of data access, loss of data quality, and some of those related issues. So I think while we'd love the golden answer, we'd love to be the shiny city on the hill in this one, I think we're also looking for some incremental progress on things that the rest of the health system enjoys on a daily basis. Other thoughts?
Yeah, Courtney, I was just going to say, I think we recognize we'll always need to work with multiple platforms and play nice with multiple platforms. The platforms we need to interact with when we're working with federal funded clients versus with our various health entity clients or health entity funders. We recognize like we're not going to have one platform for all of those, but definitely if we can automate data entry or data sharing across those platforms in an effective way, at least for our staff's contact time with the number of platforms they're working with is then minimized. And so in that way, it feels like they're only working in 1 or 2 platforms.
Great. Let me ask another question. Data ownership, AAAs. Is there clarity for your agency about your ownership of your data and who you're allowed to share it with? Or is that something that's a murky space? I'll start in Indiana.
I'm going to be cautious with addressing, but I'll say that it's murky. I'll use the option that you offered in saying that it's murky. I think the contracts that are developed are outdated at best and reflecting like the current state of even what our relationship is with the access to the data in the system that we're operating in to determine. But in terms of our ownership, that's an area that like as we've been evolving in the space, working closely like with legal counsel and like being clear and understanding what our ownership access is. So but I think I like your option of murky.
Mark?
I actually believe the data are owned by our clients at the very core. And that's because we're person-centered. But we have not really had this issue. We've been very protective in our vendor agreements to make sure that we retain ownership of the data. And so far, our healthcare partners have not been aggressive in this particular area. And we've always had just a very clear orientation to data ownership, allowing the feds in to see, or the State Unit on Aging to see our federal side of operations. So it's a little bit clearer here at Mark right now, but I think that situation is fluid and it's always a risk.
Great. Jen? age span.
As it relates to our data collection and data sharing with healthcare entities, it is very clear or somewhat clearer than I think what Indiana expressed, in that it's closer to the MARC model, where we are very careful about identifying who owns the data. As it relates to the state and our collection of information with the state, that's a much bigger question, and I don't think anyone really understands, other than the consumer who owns that data.
To
No one-
confirm, my situation is the same as yours, Jen. My response was related to our the clients with our state
I
contract.
would say, and this sort of takes data to a whole other level, but I'm committed to saying this every chance that I get. The most successful relationships that we see when it comes to data information sharing are those that include sharing in limited ways, but sharing from the EMR, and having folks who are social care experts be able to say, gosh, this person hasn't had their A1C in a year and a half, and I only know that from the EMR, not because the person reported it to me or the hospital told me, but I only know it from there. So I know that opens up lots of issues with respect to consent, with respect to HIPAA. But we as AAAs are very, very good at understanding those kinds of privacy things. And even if it's read-only access, those kinds of data sharing arrangements are the most successful in terms of outcomes.
Okay, so big question. AAAs, raise your hand if you are sharing your INR data with a SHARP, a hub, or other. Hands up. Raise your hand if you are not sharing and won't share your data with a SHARP, a hub, or other.
Courtney,
Right.
what did you mean by INR data?
Information and referral
Oh,
data.
I and R. Okay.
I
thank you.
and R, right. So oftentimes, these sharps, hubs, and others come to town and say, oh, we'll automate referrals to you, but we need your INR data. And they ask the AAAs for INR data. And I would say most AAAs will turn around and say that that is their intellectual property.
Yeah.
And constitutes their work that,
And you are
They're-
not the only victim of that request. They ask that of everyone. They provide a
Right.
shell and expect everyone else to do the work to fill
Right.
them out.
Well, and I think that the only AAAs that we're hearing about that have these relationships are relationships that have been put on top of them either by their state or by a provider that they have a contract with. So there is that real issue with the INR data. And I think it goes to the relationships, certainly with what I lovingly call intermediaries, sharps, hubs, and others. But it also is an issue that will arise in the open directory discussion. So, Jim, I see you have a hand up.
Yes, ma'am. Just so I understood that better, Courtney. So in order to get the automation suite or the automated workflows provided to you, the trade-off is to have the data, but that doesn't restrict you from having your own suite of automated process tools to do that, right?
Right. It's take Unite Us or one of those. They will come and say, we will automate referrals to you, but we need your INR data to automate those referrals. And so I have yet to find an agency that has said yes and turned that over voluntarily. What's interesting is, okay, AAAs, you haven't shared your INR data. Do you believe that the social health referral platforms are referring to you anyways? Yes. And if so, does anybody want to talk about what you think those referrals look like when they come in? Emails,
Yeah,
calls?
I feel like you set me up because I recently shared a screenshot with Courtney of what I would consider an average referral, and it included the individual's name, his date of birth, his language, his ethnicity. not his language, his ethnicity. And one sentence that says referring for education purposes. And another sentence that says, oh, by the way, he's homeless, he has these housing challenges. It'll be hard to reach him, all of this other stuff. So, you know, obviously that's a referral that's designed to fail, I think, because I don't know about you, if I'm experiencing homelessness, I could care less about what kind of education you want to provide me around managing my diabetes. I'm going to be worried about the rent first. But that's a typical referral, and I don't want to overestimate the number of referrals that we get. It's for a year, it's in the 10s and 20s, but that's very much what a typical referral looks like.
So, and Jim, one of the interesting things is when we've had conversations, at least nationally, I'll say a year ago, with some of the social health referral platforms, the selling point was we can get you more referrals. And they don't understand that this is a network that's underfunded, that has waiting lists, that I don't think any of us today lost sleep last night over getting extra referrals, did we? Getting extra referrals is not what we worry about.
So if
Taking
anything,
care
it
of
sounds
those
like
people.
you could value, I'm listening to Jennifer's example and I'm things like, you know, the referral comes in whatever form and it's read, either OCR is required or there's something else that pulls the data out from the referral and sees the word homeless. Homeless triggers a whole nother workflow in order to say, well, wait a minute, we have to see, is this available, this available? But if anything, push back to the social referral service and say, okay, fine, give me these other 6 data points or it's a no-go.
Absolutely, and not even that. If that referral comes to me and we accept that referral and we reach out to the person trying to engage them in diabetes education, and they're overwhelmed by the housing thing, and we solve the housing thing, we get the person's rent paid, or we solve the housing things, that's reflected as a failed referral. Because even though we did all of these things to make the person's life better, we did not do what he was intentionally referred to us for. So what that looks like for the healthcare system is that, look at all of these referrals we made for a simple thing like education, and there's a 0% completion rate on those. So it's much more complicated.
Right.
Yeah,
and
it sounds like it's an arbitrary threshold because you're not able to provide the other metrics to defend yourself and say, well, no, I can show in 95% of these, your reference for education was a crappy referral. Here's the other 6 things we did for them on a consistent basis.
Right, but Jen, depending who that referral comes through and what their setup is, they may only be paid for a complete referral. So all of the other work they did, even if it got this person to 97% of satisfaction on services and making headway, they didn't do that one thing that's going to trigger the completion of the pathways through no fault of their own. So there are some real issues with how the referrals come in and how that system is set up from some of these intermediaries. The other thing is going back to, and you know, James's agency and Mark certainly has their wonderful example of the referral process and the success. You know, I go back repeatedly to the assessments and the garbage in, garbage out, and what that does to both the care opportunity to provide care to that person, and then what you all are going to deal with in terms of data outcomes and what does that data look like. So there you go. Any other questions? Everybody's, as Daniel would say, we're in double, moving to triple overtime. So thank you for taking time to listen to us.
Thank you
Courtney and colleagues. It was wonderful.
Thank you. And I just wanted to thank you guys especially. I'm gonna, Brian and I have this ongoing meeting on harmonizing standards across gravity 360X and BSER for referrals. And I have this, I think it's 3 or 4 pages of questions and recommendations on the gravity standard that we worked on. And I'm going to bring up this very same issue that if you make a referral for assessment, for further assessment, do you just get the answer back, yes, the person was assessed? Do you get back the conditions associated with the assessment? Do you get back, right? Or if you make a referral for food and then in the process, they identify housing as an issue, is there something in the standard that says we want to understand all of the, the full social needs that were addressed, not just this one condition that you address. So anyways, I think these are questions that need to be addressed on the standards level as well as the funding level.
Here are the conditions that were identified by the assessment and the services that were provided in response to this assessment that you referred to us.
It's a much more nuanced. I haven't heard of anything like that described in gravity. It's always about, can you address this one health condition, this one, SDOH condition, right? But it should be played out. So
and we would not be worrying about this if it weren't for you, Courtney, going,
yep,
how it works.
Matt,
thank you.
To talk offline and share more, because we have some contracts where the health system says, do the assessment, do the SDOH assessment. And here's sort of the guardrails around the kinds of things that we are willing to reimburse for. So do the assessment, submit to us a proposed list of services as a result of the assessment. And then they have the opportunity to say, yes, we want to invest in this versus that or the other thing. So I think it even goes back further to, who are the right folks to be involved in doing the assessment.
Yeah, it's a discussion beyond technology. This is really about policy, program, a lot of things. We'd be having the same discussion if we were using paper.
Yeah.
But it's also something where, since we're right in the middle of defining the standard technologies here, that with this knowledge that this is something that is needed, we can design the technology so that it actually does support what they need.
Yeah, it seems absolutely outrageous that you wouldn't get compensated for a referral because you found the person housing, but they didn't make it through the, diabetes management program.
We should be able to return a care plan in response to a service request for assessment that then can be the basis for either further referrals or can be the basis of a contract between the MCO and the AAA, saying, okay, we're going to deliver this on behalf of this individual.
It's a great policy discussion.
Contract with little c.
Right. And I think it's critical that assessment, that care plan, and the actual care that happens should be, that person-centered care should be driving the process, and the technology supports it. And I think, unfortunately, we're in this moment of time with what's happened in really, I'd say, the last 2 to 3 years, where technology has been able to Bigfoot and try and drive new processes that haven't been there in the past, that have really been disruptive. And I think the other thing that worries me from looking at this from a national perspective and watching agencies across the country is that this is an undue burden on them. They're doing their day jobs of, trying to care for people who are in crisis all day long, every day. And now the system is expecting them to be able to engage in data exchange when the data doesn't align. They're putting burdens on them for interoperability when there has been no capital or financial investment in that infrastructure. So I find it interesting that the system consistently pushes the burden to the social care providers when they have not been given the tools and resources they need to be able to actually properly align with the rest of the system. And in the process, they're gutting some of that person-centered care that social care experts on the ground are uniquely situated to provide.
And not necessarily intentionally so, I think. In many-
Absolutely, I agree. I don't think it's
didn't occur to
intentional.
them.
Yeah, exactly, exactly. And that's why these folks need to be at the table. And thank you for letting us be at your table. We're at 6:01. We've talked for a long time. Thank you to my AAAs. You know, I love you. You guys are wonderful. You did a great
Thank
job.
you all. Thank you all.
Thank you all.
Thanks, guys.
Thank you.
Take care.
Thank
Thanks.
you.